Hello, my name is David Murray. I'm the Associate Director for Prevention at the National Institutes of Health. I also direct the Office of Disease Prevention here at NIH. I want to welcome you to Part 1 of our course on Pragmatic and Group-Randomized Trials in Public Health and Medicine. Part 1 will be the Introduction and Overview. This is Part 1 of a free 7-part and self-paced online course that NIH is offering. We will provide for each of our parts or modules an instructional slide set, a set of readings, and a set of suggested activities that you can pursue at the end of each of the sessions. So as I said, today is Part 1, Introduction and Overview. The target audience for this course is faculty, postdoctoral fellows, graduate students interested in learning more about the design and analysis of group randomized trials. We're also interested in reaching program directors and program officers and scientific review officers here at NIH who are interested in learning more about the design and analysis of group randomized trials. We assume that participants are going to be familiar with the design and analysis of individually randomized trials, also known as randomized control trials or randomized clinical trials. Participants should be familiar with the concepts of internal and statistical validity, with threats to those types of validity, and with their defenses. We also assume that participants are familiar with linear regression, analysis of variance and covariance, and logistic regression. You don't have to be an expert on these methods, but you need to at least be familiar with them, and that's one of the assumptions underlying the material. The objectives for the course are to allow you, at the end of the course, to be able to talk about the distinguishing features of group randomized trials, also individually randomized group treatment trials, which I will define in a few minutes, and certainly individually randomized trials. We want you to understand and be able to discuss their appropriate uses in public health and medicine. And for group randomized trials and individually randomized group treatment trials, we want you to be able to discuss the major threats to internal validity and their defenses, the major threats to statistical validity and their defenses, the strengths and weaknesses of various design alternatives, the strengths and weaknesses of various analytic alternatives. Finally, we'd like you to be able to perform sample size calculations, at least for a simple group randomized trial. We also want you to be able to talk about the advantages and disadvantages of alternatives to group randomized trials and individually randomized group treatment trials for the evaluation of multi-level interventions. So it's a lot, actually, that we hope to accomplish in this 7-part series, and we hope that you find it instructive and helpful. The organization of the course is shown here. We have 7 parts or modules. Today we're talking about the introduction and overview. In subsequent sessions you'll learn about designing the trial, analysis approaches, power and sample size. We'll go through some examples of group randomized trials and individually randomized group treatment trials. We will talk about the review of, or we will review recent practices used in the field. And the final session will cover alternative designs and provide references. So we'll start now with Part 1. I'm going to share with you my organization of randomized trials in public health and medicine. And I see 3 general categories or kinds of randomized trials in public health and medicine. The first of which you should already be familiar with. These are individually randomized clinical trials, often called randomized control trials or randomized clinical trials. I use all of those terms interchangeably. In these trials, individuals are randomized to study conditions, and there's no connection or interaction among participants after randomization. This is common in surgical trials, often in drug trials. It's sometimes the case in behavioral trials, but not always. And there are many behavioral trials that don't satisfy both conditions. We may start with individual randomization, but if there is some connection among participants after randomization, then it no longer falls into this category. In fact, it falls into this second category, which we define as individually randomized group treatment trials. These studies start out just like randomized clinical trials. Individuals are randomized to study conditions. But the difference is that they then have some connection or interaction after randomization. That could happen in face-to-face interaction or conversation. It could happen through an online chat session or other online service. It could happen by virtue of each member involved in the study, each participant in the study, interacting with the same change agent. For example, a therapist or a physician or other change agent. These kinds of trials are very common when we're looking at behavioral trials. Not as common in surgical and drug trials, though they certainly can happen in surgical trials if we have the same surgeon working with lots of different patients. The third category is a group randomized trial. These trials are also called cluster randomized trials, sometimes called community trials. Those terms are all interchangeable and refer to the same thing. In a group randomized trial, we randomize groups rather than individuals to study conditions, and there is always some connection or interaction among participants, both before randomization, during the study, and usually after randomization. So connection among participants is the norm in group randomized trials. It should not exist at all in individually randomized clinical trials, and it develops post-randomization in individually randomized group treatment trials. Many of the trials that we conduct in communities, in work sites, in schools, in churches involve group randomized trials. The distinguishing characteristics are summarized here. In group randomized trials, the unit of assignment is some kind of identifiable group. Could be a work site, could be a church, could be a school, could be a physician, and different groups are allocated to each condition, which means that the physicians or the schools or the hospitals or the churches are nested within conditions. And here I'm using condition to mean the same thing as study arm. So we have a treatment condition, we might have a control condition, there might be more than 2 conditions in the study. Whatever the conditions are called, we have different groups randomly assigned to each of those study conditions. In the group randomized trial, the unit of observation is the member of the group, very often an individual person, though there are certainly circumstances where we might have other units of observation other than people. But the units of observation are the members of the group. The number of groups is usually limited, not always, but often limited. As we look across public health and medicine, it's not uncommon to have 20 or 25 groups in a trial, no more. And when you think about randomly assigning 20 or 25 units, that's a very different circumstance than randomly assigning hundreds or even thousands of units as we have in randomized clinical trials. In the individually randomized group treatment trial, the unit of assignment is the individual participant, as it is in the randomized clinical trial. But the participants receive at least some of their treatment in a physical group or virtual group or through a common change agent. So this is where they depart from the randomized clinical trials. The number of groups or change agents is often limited, often just a handful. That's not necessarily helpful, but that's often the reality. Alternative labels, group randomized trials, as I said, are also called cluster randomized trials, sometimes called community trials, and those labels are interchangeable. Individually randomized clinical trials are often called randomized clinical trials, controlled clinical trials. All of those labels are interchangeable. And another set of terms that you'll often hear in this context is pragmatic trials and explanatory trials. So let me take a moment to touch on those terms just so you understand the connections. Schwartz and Lelouch introduced pragmatic and explanatory trials in a paper in 1967. They described explanatory trials as trials that test causal research hypotheses. They described pragmatic trials as trials to help users choose between options for care. These labels have been around for some time, but especially the pragmatic trial has gotten a lot of attention in the last 5 or 6 years. These terms are similar in meaning and use to efficacy and effectiveness trials. Those terms were introduced by Cochrane in 1971. Efficacy trials evaluate an intervention under carefully controlled conditions, and so are very similar in meaning to what Schwartz and Lelouch referred to as explanatory trials. Effectiveness trials evaluate an intervention under real-world conditions. Those are very similar to what Schwartz and Lelouch referred to as pragmatic trials. Pragmatic trials often use a group randomized trial design, sometimes an individually randomized group treatment trial design, and sometimes a randomized clinical trial design. So you can have any of the 3 design categories used in pragmatic trials, but quite often they are group randomized. And so sometimes people think that pragmatic and group randomized mean the same thing. They don't, but there often is considerable overlap. Let me offer a few examples. Nothing gives a better sense of what these are than examples. I'll talk about 9 studies that are conducted in collaboration with healthcare systems across the country that are funded under a UH2, UH3 mechanism by a variety of the NIHICs, and these are funded under the title Healthcare Systems Collaboratory. This is a common fund project that involves 9 studies. 8 of these, as it turns out, are group randomized trials. This was not purposeful, intentional, it just turned out that way. The investigators who submitted the applications that were approved, as it turned out, 8 of them submitted proposals that proposed group randomized trials. They're conducted, all of them in healthcare settings, but each of them has a different primary outcome, and those primary outcomes are listed here. You'll see that the primary outcomes range across a variety of healthcare areas, from management of multiple conditions to mortality in dialysis patients to colorectal cancer screening. The point is that group randomized trials can occur in a variety of settings and with a wide variety of outcomes. All of these happen to occur in the same setting, healthcare systems, but certainly they involve different outcomes. If you're interested in learning more about the Healthcare Systems Collaboratory, I'll identify 3 articles here that are published beginning in 2013, and these articles give examples of activities that are part of these 8 trials. Let me also offer some examples from individually randomized group treatment trials, and the example that I'll point to is the Childhood Obesity Prevention and Treatment Research Consortium, also referred to as COPTR. These are 4 trials funded under a U01 mechanism by the National Heart, Lung, and Blood Institute. All 4 were funded independently, but there is also a coordinating center as part of this, and the 4 trials then interact with one another, help each other. The coordinating center helps to coordinate their activities. 2 of the studies are focused on prevention of obesity in very young children, 2, 3, and 4-year-olds specifically. 2 of the studies are aimed at treating obesity where it already exists, and these are aimed at youth and adolescents. All of these studies begin with individual randomization of participants, often stratified, but individual randomization of participants. And then the participants in all 4 studies receive a substantial part of their intervention in small groups or through group activities. So all involve substantial participant interaction after randomization, and that's what makes them individually randomized group treatment trials. To learn more about COPTR, I refer you to a paper led by Charlotte Pratt from the National Heart, Lung, and Blood Institute, published in Contemporary Clinical Trials in 2013. I'm going to introduce a little notation here. This is from my book published on the design and analysis of group randomized trials in 1998. My notation is a little bit different from notation you may see in other sources, so I want to make clear how I'm defining things. I wish it were the case that there was standard notation used across stat texts and design texts and courses, but there's not. Everybody seems to use their own. There are a few places where we tend to use the same thing, but quite often we use different things, and so I want to make clear the notation that I'm using. Like just about everybody else, I use Y to refer to the dependent variable. I use condition to refer to the study conditions or arms of the trial. I use time to refer to measurement occasions, often a pretest, post-test, sometimes there are more. I use group to refer to the unit of assignment, and this is a departure for me. Many people use group to refer to study condition, and we'll talk about the treatment group or the control group. I don't use group in that way. I use group to refer to the unit of assignment because I think in terms of group randomized trials, I'm randomly assigning groups to study conditions. I refer to members to identify the units of observation. Often those are individual people, but as I said before, you could have a group randomized trial where you're randomizing people and the units of observation are teeth. So this is a common occurrence in dental studies where we're making measurements on multiple teeth in the same person. The person is the unit of assignment. The teeth are the units of observation. It's a group randomized trial even though we're randomly assigning individuals. I use X to refer to covariates quite generally. Covariates could include nuisance variables that we're simply trying to adjust for. In some cases, they might be mediators, but in general, I use covariates and speak of them in terms of nuisance variables. I will distinguish between random effects and fixed effects using bold and plain type. So in group randomized trials, groups and members are always random effects. That's why they're bolded. And condition, time, covariates are typically fixed effects. That's why they're in plain type. What's the impact on the design of the distinguishing characteristics that I showed you? Well, in randomized clinical trials, there's usually good opportunity for randomization to distribute potential sources of confounding evenly. And that's because we have the law of large numbers working for us. If we've got hundreds of participants that we're randomizing, or thousands, then we can be pretty relaxed that most of the potential sources of confounding will be distributed evenly. And confounding is not usually a concern. In individually randomized group treatment trials, because we randomly assign individuals, there is less opportunity for, there is good opportunity actually for randomization to work unless we have a limited number of individuals that we're assigning. We often don't have hundreds or thousands. We often have less than 100. And to the extent that that number gets smaller, randomization may not have the same opportunity to work effectively. So confounding can be a concern in individually randomized group treatment trials. In group randomized trials, we almost always have a limited number of groups. There are certainly exceptions where there may be 100 or several hundred, but often the number is less than 50. And as a result, there will be limited opportunity for randomization to distribute potential confounders evenly. If we got to do the study hundreds of times, we wouldn't worry about it. But since we only get to do the randomization once and the study once, confounding is usually a concern in a group randomized trial if we have fewer than 50 groups. The impact on the analysis is also important. Observations in trials where we randomize individuals who don't have any interaction or connection post-randomization, those observations are independent. We can use the usual and familiar statistical methods, standard methods, like linear regression, logistic regression, analysis of variance, and so forth. Those are the methods that you all learned in your graduate courses. And those are fine as long as the members that we're observing, or the individuals that we observe, are not interacting with one another, don't share connections post-randomization. With group randomized trials and individually randomized group treatment trials, we do have post-randomization interaction, sometimes pre-randomization interaction, and so the usual methods can't be used in the same way. The members of the same group in a group randomized trial will share some physical or geographic, social, or other connection. Those connections will exist before we ever show up on the scene to conduct the study. The students who attend the same school have grown up together often, play together, attend classes together. And so there is very naturally a series of connections among the students attending the same school. That will also be true of workers in the same work site, or often patients who see the same physician. If we create groups in an individually randomized group treatment trial to deliver part of our treatment, the members of those groups will often develop similar connections over the course of the study. These connections create an expectation for positive interclass correlation that reflects extra variation attributable to the group. So what is an interclass correlation? You can think of it as the average bivariate correlation among members of the same group, and it simply reflects the connections or commonalities that those members share in common. That often small correlation reduces the variation among members in the same group, so the within group variation is shown as written here. We multiply the usual variation of the dependent variable sigma squared y by 1 minus the ICC. And this is the ICC among members in the same group with groups nested within conditions. The between group component is the one's complement. So now we take the usual variance, sigma squared y, and simply multiply by the interclass correlation. The interclass correlation is usually a small number, a small fraction, and so the group component is usually small relative to the member or residual component. The total variation, sigma squared y, is still the sum of the two pieces. Another way to think about the interclass correlation is as a ratio or a fraction of the total variation in the data that's attributable to the group or the unit of assignment. What's the impact on the analysis? That's shown here. If we establish group membership by random assignment, that is, randomly assign members to groups, the variance of the group mean, written sigma squared y bar sub g, is simply the usual variance of the dependent variable, sigma squared y, divided by m, which is the number of observations contributing to the mean. So you've all seen this formula before. You saw it in your first graduate statistics course. You just haven't seen it with my notation. This is the variance of a mean, which is always the usual variance divided by the number of observations contributing. And if group membership is established by random assignment and the members never interact with one another or have any other connection, that first formula applies. When group membership is not established by random assignment, we have an extra component of variance, that attributable to the groups that we talked about a moment ago. We also have the residual variance, or member portion of the variance, sigma squared e, and that member component is divided by the number of observations contributing to the mean, but the group component is not. Another way to write that expression is in the third equation, which is probably more familiar to those of you viewing this material. Now the variance of the group mean in a group randomized trial is the usual variance of the group mean, sigma squared y divided by m, multiplied by this parenthetical phrase, 1 plus m minus 1 times the ICC. This parenthetical phrase is sometimes referred to as a variance inflation factor, sometimes referred to as a design effect. Many of you will be familiar with design effects from cluster sampling context in the survey sampling course, and it's exactly the same thing here. The interclass correlation multiplied by m minus 1. If the ICC is small and m is small, the product will be small, and so the variance inflation factor or design effect is not very large. But if m is large or the ICC is large or a little bit of both, that parenthetical piece can be large and the variance inflation factor then can be large. Nested factors must be treated in the analysis as random effects. This is based on a paper from David Zucker, published in 1990. He was a biostatistician at the National Heart, Lung, and Blood Institute at the time. We worked together on a study called CATCH, the Child and Adolescent Trial for Cardiovascular Disease. And David was very influential in helping me to understand these issues, and this is a very important paper of his published in 1990. The variance of any group level statistic will be larger because of that variance inflation factor. The degrees of freedom available to estimate group level components of variance will be based on the number of groups, and so usually smaller or limited. This is always true in a group randomized trial, often true in an individually randomized group treatment trial. If you ignore either the extra variation or the limited degrees of freedom, you're going to have an inflated type 1 error rate, and you don't want that. How bad can it get? In a group randomized trial, the type 1 error rate might turn out to be 50% or 60%, not 5% as you might like it to be. In an individually randomized group treatment trial, it could be 15 or 20 or 25%. And you don't want any of those levels for your type 1 error rate. So you definitely want to avoid that. Extra variation and limited degrees of freedom also serve to reduce power. So even if you do the analysis correctly so as to avoid the type 1 error rate inflation, you may have limited power unless you've planned for it. Another way to look at the impact on the analysis is using an equation from Scott and Holt, published in 1982 in JAZA. This expression is another expression for the variance inflation factor or the design effect, and it's written as 1 plus m minus 1 times 2 ICCs. ICCY here is the same one that we were talking about a moment ago. It's the interclass correlation for the dependent variable. ICCX is the interclass correlation for the independent variable. And quite generally, the design effect is the product of the two interclass correlations times m minus 1, where m is the number of members per group, and then we add that product to 1. To the extent that the ICCs are positive and m is greater than 1, the product will be greater than 1, the design effect will be greater than 1, and there will be variance inflation. Normally in group randomized trial or individually randomized group treatment trial, the ICC for the independent variable, that is ICC sub x, is 1, has a value of 1, because everybody in the same group gets the same treatment. When that happens, ICC x simply drops out of the equation, and we're left with the expression that I showed you before. For most health outcomes in public health and medical research, we see ICC values that are usually pretty small. If we're working with large aggregates like schools, work sites, communities, counties, things like that, the ICCs are usually less than 0.05. If we're working with somewhat smaller aggregates like classrooms and departments, the ICCs are going to be larger, may range up to 0.25. And if we have very small aggregates like spouse pairs or families, the ICCs can be quite large. We see values in the 70s. The ICCs also tend to be larger for certain kinds of outcomes. So if you're measuring knowledge and attitudes, you're going to have larger interclass correlations than if you measure behaviors. The smallest ICCs tend to be associated with physiological measures. If the groups are crossed with the levels of the exposure, and that's true in most observational studies, the two ICCs will have essentially the same value, and you have a product of two often small numbers. If the groups are nested within the levels of exposure, and that's going to be true in a group randomized trial and in individually randomized group treatment trials, the interclass correlation for the independent variable will be 1, as I said, because all members of a group will have the same value on exposure. This table summarizes the effect in a quantifiable way. The left-hand portion of the table shows the kind of situation that we're dealing with if we're doing a survey. So we have observational data. We may have used cluster sampling to collect our data because we couldn't easily enumerate the entire population. And so we select blocks, and within blocks we may select people. Interclass correlations for most public health and medical research tend to be small, as I said earlier. And I've got examples here of 0.05 and 0.01. With surveys, the groups that we're working with, which are in primary sampling units, tend to be crossed with the exposures that we're interested in. So we might see different levels of education in every primary sampling unit. We might see different, both levels of gender in every primary sampling unit. So, and if those are the exposures that we're interested in, then the exposures are crossed with primary sampling units. The two ICCs tend to be of similar magnitude. We multiply the two numbers, we get a small product. The sample size varies from a small number to a larger number, but the design effects, because we're working with two small ICCs, tend to be small. So even if we have a survey with 200 people measured in each primary sampling unit and an interclass correlation of 0.05, the design effect is only 1.5. And we don't pay too much of a penalty in terms of variance inflation. If the ICC is even smaller, we may inflate the variance only 2% or 3% or 5%. And so we're not paying much of a penalty. We have a different situation with individually randomized group treatment trials and group randomized trials. So if we look on the far right where we're talking about group randomized trials, the sample sizes tend to be larger in group randomized trials. In school studies, for example, we might measure 500 people in every school. The interclass correlations tend to be similar, but the interclass correlation for exposure is going to be 1, and so we don't get the benefit of multiplying two small fractions together. We're multiplying 1 times a single small fraction. And the design effects as a result then are much larger. We can have design effects in the teens, in the 20s. In a study that I worked on at the University of Minnesota called the Minnesota Heart Health Program, we famously had design effects in the low 30s for some of our outcome variables, and that was pretty painful for us. And the pain is demonstrated in the formula at the bottom of this slide. We need to correct for the extra variation when we conduct a proper analysis or a correct analysis. And if we take the incorrect or uncorrected f-test, the way to correct it is to divide by the design effect. And I'm sure that not many of you would want to take the usual f-test from your analysis of variance or your regression analysis and divide by 20 or 25 or 30 or even 5 because that gives you a corrected value that's much, much smaller and far less likely to be significant. So the penalty can be substantial, and it's something that we need to be concerned about. Jerry Kornfield warned us about both of these problems in a famous paper published in the American Journal of Epidemiology in 1978. This is one of my favorite quotes, and I share it with people whenever I get the opportunity. Randomization by cluster, accompanied by an analysis appropriate to randomization by individual, is an exercise in self-deception. I love the understatement. So you all have now heard his warning, you've heard my warning. Be advised and don't do this. Cornfield's remarks were addressed only to group randomized trials in 1978, but they are equally applicable to individually randomized group treatment trials. If you are working with a group randomized trial or an individually randomized group treatment trial, you simply cannot use the standard methods that operate as though you had randomized individuals that had no connection, no interaction with one another post-randomization. If you ignore that advice, you're going to have an inflated type 1 error rate, and you'll mislead yourself and the research community with the results that you publish. So in summary, a group randomized trial is the best comparative design available when the investigator wants to evaluate an intervention that meets one of several conditions. So you could have an intervention that operates at a group level. That is, the people need to interact with one another in order to have the intervention effect that you hope to have. And there are many interventions like that, many group-based interventions where the discussion, the interaction among the participants is critical to the theoretical processes that underlie the intervention. Another characteristic of an intervention that calls for this kind of design is one that manipulates the social or physical environment. So you might want to change the menus in the restaurant as a way to try to encourage people to order items that are lower in fat or lower in salt, for example. Or you might want to put labels on the displays in the grocery store to try to encourage people to buy products that are lower in fat or salt. So you're changing the physical environment when you do that. And all of the people who go into those stores or restaurants are exposed to that. And it's very difficult to randomize individuals to receive those kinds of treatments as opposed to groups. And then finally, you may have an intervention that you're concerned cannot be delivered easily or safely to individuals without substantial risk of contamination. This is one of the major reasons that we move to group randomized trials. So in school-based studies, for example, if we're trying to conduct an intervention where we teach kids how to resist social influences to start smoking, we know that the kids that receive that intervention, even if we deliver it to one kid at a time, those kids are going to interact with one another at recess or in the next period. And they may talk about the intervention they received. And if we try to have intervention and control participants in the same school, we have a serious risk of contamination. And this is one of the reasons that many school-based studies randomize schools rather than individuals. The individually randomized group treatment trial, I would argue, is the best comparative design when individual randomization is possible, but there are good, often logistical reasons to deliver the intervention in small groups. It may simply be financially infeasible to deliver the intervention to individuals and may be far more economical to deliver it to groups. The challenges for all of us are to create trials that are rigorous enough to avoid the threats to validity of the design. We will talk about that in an upcoming segment. To be analyzed to avoid threats to statistical validity. We will also talk about that in an upcoming segment. And powerful enough to provide an answer to the question. We will talk about that in an upcoming segment. We certainly want these studies to be inexpensive enough to be practical, and if we design them well, we can usually accomplish that. So I want to thank you for your participation in part 1 of our course on pragmatic and group randomized trials in public health and medicine. I encourage you all to visit our website. The link is provided here in slide 23. From that website, you can provide feedback on the series. Please give us any comments, suggestions for additional material, improvements to the course. You'll find all of the references that I've cited today and will cite in subsequent segments. You'll also find some suggested activities that you can pursue on your own so that you can get more out of the material that we've reviewed today. Finally, you can certainly view the next module in the series, the next segment, part 2, which focuses on the design of the trial. Let me also encourage you, if you have any questions about the material that I presented today or about the course in general, please send us an email, grt@mail.nih.gov. We'll look those over and send you a response as soon as we can. We encourage you to do that as you have questions. Thank you very much for your attention today, and look forward to visiting with you in part 2.